Thank you, Millie, and welcome, everyone. A bonus, if you hand in your cards as you leave, you get vaccinated. Just joking. So today I'm going to talk more about vaccination in the spotlight, but also general health maintenance. And the important thing to recognize is there are many aspects of health maintenance we treat patients with IBD. Bone health and disease, cervical cancer screening, we'll review those guidelines, skin cancer screening, and prevention of infection, which is really the biggest one we know a lot about, but there's other data that we'll go through. And Millie referred to these guidelines, and these are things that were positioned by the American College of Gastroenterology, and we're all fortunate enough to be involved in their assimilation, really representing the first preventative care guidelines for IBD that have come forth. And I refer you to read these at your leisure. They were published last year. But to go through, we'll start with some simple things, bone health. And in general, we say patients with IBD have an increased risk for osteopenia and osteoporosis and osteoporotic fractures. So these are things recognizing that it's important to look at individuals. Check vitamin D status, and there's now 3 small trials that show it helps disease activity as well. Small investigator-initiated, not large randomized placebo-controlled trials, but these are not only for the benefit of bone health, but as well supplementing with vitamin D is important for that purpose. Adequate calcium, vitamin D, 400 to 800 international units, and if low, it may be higher. One might give 50,000 international units twice weekly for a period of 3 months to get high enough, and subsequently lower dosing. Consider bone density assessment in patients that have risk factors. Postmenopausal men and women over the age of 50, prior history of fracture is something that obviously signals that someone should be screened. Individuals that have comorbidities such as use of corticosteroids, and one would argue it's 5 to 7.5 milligrams for over a short period of time is considered adequate, but again, within 2 years prior is reasonable. And then also people that have hypogonadism, a history of osteoporosis to follow up in that have had family histories as well, and certainly malnourishment. People that are malnourished and women under the weight of 120 is the best published in the medical literature, if you would, directly. Additional risk factors, chronic inflammation, smoking, and malnutrition as well. So if we look at this, the way to approach things are individuals, if they're on medications which reduce bone density, steroids, cyclosporin, methotrexate historically have been associated with that, or they have conventional risk factors, then do a bone density. If the bone density is considered to be abnormal, follow that up in about 1 to 2 years in general. If it's normal, there's no change in the status, and then follow up if they have concurrent risk factors that have come about. So there's some statements that are in the American College of Gastroenterology guidelines, and statement 10 was with women with IBD who are on immune suppressive therapy should go annual cervical cancer screening. It's a conditional recommendation, and the real reason there was very low level of evidence is because the data was not assimilated in primary trials in women that were at risk, but it is inferred from other data. So cervical cancer screening due to persistent infection with HPV is a general consensus, and over 70-some million Americans are such that they have exposure, and newly infected is a very common scenario. Most, but not all, have an increased risk of cervical cancer when they're immune-compromised IBD patients, and that's really the group that we're going to focus on here tonight. Up-to-date pap smears are important in individuals, and ideally, prior to starting immunosuppressive therapy would be the ideal time, but it's certainly not the only time. In the age groups of 21 to 29 is when to start. There are certain guidelines that suggest every 3 years, but again, testing for HPV is not recommended at that age, and these are the standard current guidelines. Women age 30 to 65 should be tested every 5 years, but again, these are not for immune-compromised hosts. One of the things to recognize is HPV 16 and 18 account for 80% of all cervical cancers. And that's an important issue to recognize, and also anal cancer they're associated with. And women with IBD have an increased risk of abnormal pap smears in most studies, but not all studies, to suggest this is something that we should be doing such. And more than 6 months of immune modulator use has been suggested to be appropriate to put them at a higher risk. Again, it's not well studied in randomized trials, but this is inferred from retrospective data. And higher risk for the serotype 16 to 18. So HPV vaccine is available. It's safe in even women and young women on immune modulator therapy. So that's to start with. You're going to hear more about this, but this is an overview. Skin cancer screening. 1 in 5 Americans get skin cancer by age 70. It's the most common cancer there is. And it's always excluded in the large number of the studies because it's not systematically looked for. But non-melanoma skin cancer, which is basal and squamous cell for the most part, 3.3 million were based on the most recent data we have is 2012 from the American Cancer Society. There is no increased risk at baseline for patients with IBD. Whereas melanoma, on the other hand, is less common. About 91,000 cases are expected to occur in 2018 based on CA, which is the Cancer Society Journal. And it's more serious, obviously. It can lead to deaths. And this accounts for the majority of skin cancer-related deaths are due to melanoma. There's an increased risk independent of treatment, and Millie, Ed Loftus, and others had really published this data. The IRR was 1.29, so it's a slight increase. It's not severe, but it's enough to say do an examination on patients directly. Non-melanoma skin cancer with thiopurines, these are some of the landmark studies that were done. There's an increased risk, and careful examination should be done. With biologics, it's increased as well. I think it's mostly driven by the thiopurines, though, if you look at the studies. And part of the flaws of the older studies are patients were on immune modulators plus biologics, and they didn't parse out the difference between that. Millie's really been a force to être in this area and has published the most data related to this, along with the French have really published a good amount of the data with the Jetade study group. Non-melanoma skin cancer in combination is increased, and melanoma itself with thiopurines is not thought to be an issue. It's the non-melanoma skin cancers directly. So this is one of the landmark papers. Laurent Perron-Biroulet published data, thiopurines associated with non-melanoma skin cancer. As you can see on the left, less than 50 years, 50 to 65, and greater than 65, so there's an age dependency. Additionally, you can see those that continued are in the, actually it switched. Those that continued are not the blue, but should be the gray. Somehow it got transposed. And the gray has the higher overall risk directly, and those that never received are the lowest. So if you stop the use of a biologic agent or a thiopurine, your risk for skin cancer persists forever. So continued important checkup, whereas the risk for lymphoma, when we look at azathioprine or 6-MP, is such that it goes down to that of the general population, and the risk is no longer escalated when you stop the drug. Depression. 15 to 35% of IBD patients, based on recent data from Journal of the AMA, really suggests that this is prevalent in patients. It's relapsing disease nature, the chronic pain, and the steroid use that are thought to be operant in the association with development of this. The American College of Preventive Medicine, the U.S. Preventive Task Force recommends screening. And 2 questions to ask if you're in clinic are, over the past month, have you felt down, depressed, or hopeless? And over the past month, have you had little interest or pleasure in doing things? And those are perceived to be good screening questions to ask. So when you go home, start asking your patients. It's easy enough to do, and these are things that we do in all patients we see. Cigarette smoking. One of the best things you can do is have a patient stop cigarettes. And this is a recent meta-analysis published that looked at the data, 13 studies, over 11,000 patients with ulcerative colitis. Current smoking is protective for ulcerative colitis. It's the risk of MI, CVA, lung cancer, and other things that preclude us from giving it. So it's always What's the risk? What's the benefit? The risk is very clear. The benefit is not enough to suggest that. Now, quitting smoking is also associated with UC activation, so it's protective when they go back and they smoke again in former smokers, but don't do that in general. Whereas Crohn's, the opposite occurs. 9 studies over 10,000 patients, current smoking is associated with the onset of Crohn's, and former smoking is weakly associated with Crohn's. But I think smoking cessation is one of those things we do. Less post-op recurrence, less fistulizing disease as well. So I think these are things that we should strongly engage our patients and say, stop smoking. There's many measures you can do, and these are just some of these that are outlined. You can use nicotine products, you can use over-the-counter patches, you can use prescription patches, you can use non-nicotine medication, buprone, Varicline, a host of things directly. And then counseling is very important. These should not be done in a vacuum. You need to counsel the patients and really discuss appropriately. And if you're not going to do that, refer them to their primary care provider to do so accordingly. Hep B. If you have hepatitis B surface antigen prior to the introduction of a biologic, particularly an anti-TNF, your reactivation risk is astronomical, 39%. In the initial study that led to this, there were 4 deaths. So this is important. There was no antiviral treatment in this population. If your core antibody is positive, it's anywhere from 2 to 5% rate of reactivation within a year. So you need to monitor these patients periodically if they reactivate while they're on a anti-TNF directly. Vaccinate. Hep B. Those patients at risk, healthcare personnel, high-risk individuals, men having sex with men, multiple sex partners, IV drug users, multiple transfusions, tattoos, the standard things we think of over the years. And anyone who wants a vaccination should get a vaccination, in my opinion, as well. And these are currently the recommendations that we had in our guidelines. Screening before starting, Hep B surface antigen, core antibody, and surface antibody directly should be the 3 tests you do in an effort to define if someone's been exposed. Infection. As Millie alluded to, infection is one of those issues that we really try to avoid in patients with IBD. Now, the problem is there are many risk factors that patients with IBD have that associate with a higher risk of infectious complications. The immune suppressants, the disease activity itself is a factor directly, and there's a higher mortality with the disease itself. One of the first studies we published was a treat registry, and we looked at this directly. And if you look on the right side is serious infections, on the left is mortality. Infliximab, anti-metabolite therapy, and steroids are there. And if you see, steroids are always the highest, whether it be mortality or whether it be infectious complications. This has been seen in numerous other studies. The other thing I should mention is narcotic use was associated with double the mortality, double the severe infectious complication risk. So as a consequence of that, these are things we try to avoid or limit exposure to in general. Pneumonia risk is increased in IBD, and one of the most common reasons patients die with IBD is pneumonia. So it's one of those things that clearly should be looked for. And Millie publishes data, one of the first studies looking at this. Crohn's disease, ulcerative colitis, with IBD and the controls, the adjusted hazards ratio are about 1.5-fold, 1.7. When you look at Crohn's, ulcerative colitis are all combined. Vaccines in IBD. Looking at this, you'd say, here's those that are at risk, here's those that are vaccinated, and this is a very nice study that was done, and Gil had published some of this data, and directly you can see, unfortunately, the blue is those that were vaccinated that were at risk. So the issue is the majority of patients with influenza, pneumococcus, varicella, Hep B, and tetanus have really not received vaccines that are at risk in clinic. And I can vouch that in our clinic when we see patients from other providers, many times they don't have the vaccines that they need, and we strongly advocate they get that. We give them a list. We either do it directly in our pharmacy or we send them out to other pharmacies to do it. And you can send them to a local pharmacy, a CVS, a Walgreens, whatever it is, and give them a script and say, here, get your prescription if you don't give it in the office directly. These are things that should be considered in the appropriate population. Now remember, live viruses with immune modulators are not those things we want to give, except for one caveat, and we'll talk about that. So live inhaled flu should not be given. The CDC took it off the list of things, and they put it back on the list of things that they now give in the most recent rendition. As of January 2018, it's back on the list. It was off for a while. But that should not be given. Measles, mumps, rubella. Varicella is a live virus, so don't give a varicella vaccine. But the current zoster vaccine, which is a recombinant vaccine, is enabled. We can do that. Whereas the old vaccine, the inactivated vaccine, one can do if you have immune modulators, azathioprine less than 2.5 milligrams per kilogram, 6-MP less than 1.5 milligrams per kilogram, methotrexate less than 0.4 mg per kilogram, or 20 milligrams of prednisone less than 2 weeks or less are the standards based on the ID Society recommendations. And these are standards, so you can do that with the prior vaccine before the attenuated vaccine. And I'll mention the name of the vaccine so people know, Shingrix. You know, this is the current vaccine that we have that is attenuated. Oral typhoid, yellow fever, rotavirus, BCG, which is really a bacterial vaccine. It always gets listed under the viruses, so I wanted to point that out, that is not a virus. And then some uncommon ones, vaccinia. You can't get that in the United States, so you can't vaccinate. MMR, varicella, chickenpox, oral typhoid, and yellow fever is also a live virus. So if people are going for these, avoid the use. And the typical time frame is 4 weeks after vaccination that you want to wait if they've had a live virus before they go to get any immune modulator. So vaccines to consider in the adults: Hep A, Hep B, HPV, influenza, pneumococcal pneumonia. And we're going to talk about the two types of pneumococcal pneumonia, the PSV13 and the PSV23 as well. Zoster, recombinant, and varicella should be considered. And this is currently the CDC recommendations. If you go on cdc.gov or the Annals of Internal Medicine, you'll see the recommendations. And this you can get on the slides you can download afterwards directly. And then there's those that are immune compromised as well. And the list of the vaccines there directly are important to recognize which ones to give and when. So the key thing you want to do is there's certain things you need to do in the office initially. There's certain things you want to check with regards to has a patient been vaccinated, and then one wants to go and then treat them accordingly. And Gil's going to touch on this to some degree, so I'm not going to focus on this too much. Influenza is higher in patients with IBD than controls. And this is some of the data that has shown this. There's certainly other studies. But also, not only is influenza more common than in IBD patients than in controls, the influenza that is obtained is at a more severe rate. It's more virulent. So pneumonia risk is increased in IBD. Somehow we're going backwards here. And this is important to recognize, and this is, again, Millie's data. But also recognize invasive pneumonia is the key thing you worry about. So strep pneumonia is a leading cause of sepsis, pneumonia, meningitis, and also severe ear infections. And high-risk groups are over the age of 65 who are immune suppressed. So the PSV23 is not a live vaccine. It's a dead bacteria, and it's 23 serotypes. There's over 90 subtypes of pneumonia. So this will help with 23. The PSV13 is another 13. Zoster is important as well. Crohn's and ulcerative colitis have a higher rate of zoster than controls. And here's some of the data. Again, Millie publishes data. Jim Lewis in our group published the initial study that was in the GPRD, which we'll talk about later as well. So when you prepare for immune suppression, get a vaccination history. Find out what they've had. Ask social travel, occupational history, infections. Bring your vaccines up to date. If you're going to use an immune modulator, check your TPMT enzyme activity. Before anti-TNF, check for HPV and TB. A gamma release assay would be appropriate. And then natalizumab, if you're going to use, check JC. And then ustekinumab and veto, check HB and TB as well. These are the things we do in advance. There's ongoing therapeutic monitoring as well, which is very familiar to the group, and this is something I'm not going to spend time on, but it's in your appropriate slides you can review in the future. And these are things that are important to do once you're on the drugs. So who gets vaccinated for flu? Everyone over the age of 6, and then those at high risk. And then the main choice is the inactivated killed vaccine versus the inhaled vaccine. And then multiple studies over the past year, so IBD is not generally affected by the immune status. The immune suppressant is generally such that if you're on immune suppressants, you should have a flu vaccine regardless. And it did not worsen disease activity. So to summarize, there's a couple things to do. Vaccinations, influenza, pneumococcal pneumonia, zosters, Hep A, Hep B should be contemplating because reactivation of Hep B can be very serious and can be lethal. DEXA scans in appropriate patients, frequent dermatologic evaluations, particularly those on immune modulators, and generally in patients that have IBD because of the higher risk of melanoma in that population directly. And then subsequently every year or two, depending on what's found, or even more frequent. Depression screening in all patients, tobacco cessation should be counseled, pap smears if immune compromised on an annual basis, and then latent TB screening initially prior to introduction of biologics, and then I do on an annual basis. A gamma release assay is appropriate just because there may be acquisition of TB, and if you read the package insert, it's in there. It suggests periodic monitoring. And then steroid use as well, monitor for the appropriate bone density. A few other things, it's okay to give live vaccine to household contacts of immune-suppressed IBD patients. Rotavirus is given at 6 months, but use hand washing and diaper changes, obviously if you have the baby. And varicella and zoster, avoid household contacts if there's active rash, because a rash is a contagious thing for a period of time. And then vaccination to infants of newborn mothers on biologics, defer live vaccine rotavirus until the infant's over 6 months, or check the infant drug level and administer when there's no detectable drug. So I'll stop here and turn things over to Gil, who's going to continue.